So, it's better we start.
Yes.
So, Assalamu alaikum. Good evening, everybody. And thank you for being with us this night. And Oman Diabetic Association is glad to bring you to this series of LaSave. We call it LaSave series, and this is number 10. So we aim from this series to learn, apply, and save a diabetic patient. So please make sure whatever you learn today and from previous sessions, you bring it to practice and save a diabetic patient and improve care for diabetes. Women Diabetic Association always striving to bring excellence in diabetic care through promoting science and public education for community about how to care for diabetes, and also among healthcare professionals, how to provide a better care for diabetic patient. We welcome all for this tonight, and today we are glad to have Dr. Bushba. Dr. Bushba is a specialist ophthalmologist at the National Diabetic and Endocrine Center here in Muscat, and she will talk about very important topic is diabetic retinopathy. As we know that diabetes is very devastating disease if not treated properly. Complications are very potential and very serious. People, they lose their vision, they lose their kidneys, they lose their limbs. So our aim is to prevent as much as we can through optimal management of diabetes. And if that does not work, for all early detection of complication and also for providing post-complication care. So today we will talk about very important issue, diabetic retinopathy, and how to prevent blindness actually among diabetic patients through early detection, good management, and post-care management as well. So Dr. Abushba, you are most welcome for this session for 30 minutes, and then we'll follow up with question and answer session. Everybody to ask, as usual, you can raise your hand and the mic will open for you, or you can put your question in the Q&A section and we will answer your query. So Dr. Abushba, thank you very much for accepting our invitation, and the floor is yours.
Okay. So shall I share the screen?
Yes, please. Yes, please. Yes, it is working.
Yeah. So good evening, everyone. Good evening, Dr. Ahmed. Good evening, Swat. And I'm Dr. Pushprata Agroya from National Diabetes and Endocrine Center. Today, I'm going to present my topic, diabetic retinopathy. Diabetic retinopathy is a serious microvascular complication associated with diabetes, which is a leading cause of blindness as well as visual impairment worldwide. Despite extensive efforts to reduce the visual impairment, the prevalence is still increasing. So the outline of my presentation will include the following headings. We will discuss about the prevalence, risk factors, pathogenesis classification, then manifestation and workup for the patients, and little about the management. Coming to prevalence, diabetic retinopathy is a leading cause of new cases of blindness in people aged 20 to 74 years. It has a considerable impact on both the patients and the society because it typically affects the individuals in their most productive years. Blindness is seen to be 25 times more common in diabetics than non-diabetics. The Vision Loss Expert Group, VLEG, reported that diabetic retinopathy accounted for 1.25% of moderate to severe visual impairment and 1.07% of blindness. A meta-analysis was recently conducted which showed that diabetic retinopathy caused blindness in regions with older population involving like countries like Eastern and Western Europe and Southern Latin America, compared to the regions with relatively younger population. So it affects the older population mostly. Prevalence of proliferative diabetic retinopathy and severity of diabetic retinopathy is much more common in type 1 patients compared to type 2. The 25-year cumulative rate of progression of diabetic retinopathy in type 1 was progression of diabetic retinopathy seen in 83%. Progression to proliferative stage was seen in 42% and macular edema was seen in 26%. So it is very surprising that 6 of the 10 countries with the highest prevalence of diabetes in the world are in the Middle East, and our Oman is also one of them. And the prevalence of diabetic retinopathy ranges from 19% in UAE to 64% in Jordan. Regarding the type of diabetes, we have observed that diabetic retinopathy is seen in about 33% to 42% of type 1 patients and 23 to 25% in type 2 diabetes in different studies conducted worldwide. But still, if we see the screening scenario, currently only 60% of people with diabetes have yearly screenings for diabetic retinopathy. This may be due to the lack of awareness in patients itself, and they are not very compliant, and sometimes they just ignore because vision is not affected in early stage until there is diabetic macular edema or there is a proliferative retinopathy causing the vitreous hemorrhage. The patient will not experience much visual disturbance, so they tend to ignore it. We also conducted one study at our center, and the prevalence of diabetic retinopathy was found in 31% of patients in our center, and the prevalence of vision threatening diabetic retinopathy and diabetic maculopathy was quite high, reaching to around 15 to 20%. Prevalence of diabetic retinopathy after 20 years of diagnosis is seen almost in 100% of patients with type 1 and almost 60% of patients in type 2. Coming to risk factors, so far duration is the most important risk factors for development of diabetic retinopathy, and after 5 years, it is seen in 25% of patients. After 10 years, 60% are affected, and after 15 years, 80% are affected. Age at diagnosis is also very important. In type 1 diabetics, the first screening should be done after 3 to 5 years of diagnosis. And in type 2 patient, it is done at the first diagnosis of the diabetes. Because it is found that in 5% of patients, they show diabetic retinopathy at the presentation or at the diagnosis of the diabetes. It is shown in various studies that poor metabolic control leads to the early development of diabetic retinopathy and rapid progression. So metabolic control is the key to manage the diabetic retinopathy. Pregnancy also causes the rapid progression. This is associated with the pre-pregnant stage of the disease and also with the poor control and associated preeclampsia and associated high HbA1c. Usually, if the severity of the disease is more in pre-pregnant stage, it is likely to progress very rapidly. And also it is seen that diabetic macular edema, if it develops during pregnancy, it resolves without treatment after the pregnancy. Hypertension, nephropathy, hyperlipidemia all lead to rapid progression, and various studies have already shown that the better control of blood pressure and better control of lipid profile will lead to delay in the development and slow down the progression. Nephropathy, it is seen that nephropathy is associated with diabetic retinopathy, and worsening of nephropathy also causes worsening of the diabetic retinopathy. Whenever patient is receiving the renal transplant, it is seen that their diabetic retinopathy is also improved, and they show better response to the treatment for diabetic retinopathy. So they have a vice versa relationship. Anemia, sleep apnea, hyperproteinemia also causes are associated with diabetic macular edema and causes early development. So if we control all these factors, there will be delay in the development of the diabetic retinopathy. Obesity and smoking also causes diabetic retinopathy to start early. Cataract surgery during the in diabetic patient also related to the rapid progression, because during the surgery various inflammatory mediators are released, which causes the development of the diabetic macular edema. Hereditary factors are more on have effect on more effect on proliferative diabetic retinopathy. Coming to the pathogenesis, diabetic retinopathy is a microangiopathy affecting the retinal precapillary arterioles, capillaries, and venules. The basic changes which we see are capillopathy, some cellular damage, and ultimately leading to neovascularization. In retinopathy, it has both features of microvascular leakage, which is seen in mild to moderate non-proliferative diabetic retinopathy, and microvascular occlusion in severe and severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. So capillopathy comprises of they will be thickening of the basement membrane. There will be loss of pericytes, endothelial cell damage, more endothelial cell proliferation. There will be some hemodynamic changes, some rheological changes, changes in the RBC and changes in the leukocytes. There will be increased platelet stickiness will be there, increased plasma viscosity. All these leads to occlusion, and weakened capillary wall lead to outpouching of the secular shaped microaneurysm, which either leak or leakage, it cause leakage and causing the hemorrhage and edema, or it may be thrombosed. Microvascular occlusion leads to retinal ischemia, finally leading to retinal hypoxia. Once retina undergo hypoxia, it elaborates various vasoformative substances like VEGFs. One of the most important vascular endothelial growth factor is VEGF-A. Other factors are like platelet-derived growth factors and hepatocyte growth factors are also released, which induce the angiogenesis and formation of neovascularization. There is also increased fibrous glial proliferation, neovascularization, and there will be formation of arteriovenous shunts. So as I have discussed, due to these vasoformative substances, there will be neovascularization. Simultaneously, there will be release of some angiogenesis inhibitors like endostatin and angiostatin. So the neovascularization will depend on the balance between all these angiogenesis stimulators and angiogenesis inhibitors. So as I have discussed, intraretinally, the neovascularization will form AV shunts between the arterioles and venules. This is hypoxic retina, elaborating the vasoformative substance leading to AV shunts or IRMA. And pre-retinally, there will be formation of NVD, NVE, or pre-retinal neovascularization. Finally, leading to, in more advanced stages, rubeosis iridis or NVI. There will be loss of pericytes leading to formation of secular outpouching leading to microaneurysm formation, which causes microvascular leakage. It will manifest as hemorrhage and retinal edema. Retinal edema may be of two types, diffuse and localized, which is surrounding a single microaneurysm with a sectoral macular edema. So whenever the patient is diabetic and he is already having diabetic retinopathy, what are the normal visual disturbances he will face? He will have difficulty with fine details and while reading also and watching television, because diabetes also affects the accommodation and weakens the ciliary muscles, and it affects the macula, so the near vision is affected and the fine detail will be not very clear. He will have difficulty with outdoor travel, outdoor activity. He will experience visual fluctuations from hour to hour, day to day. They will be with the hyperglycemia or hypoglycemia. There will be changes in the thickness of the lens, which causes physiological myopia or hypermetropia, leading to changes in the refractive index. He will see image as rippled. Straight lines will appear bent, because this particular feature is seen whenever there is presence of the macular edema or there is presence of the epiretinal membrane. There will be blurring of vision, hazy or double vision. As we know, the diabetes also causes the rapid or early development of the cataract and glaucoma also. So because of the glaucoma also, there will be blurring and double vision. There will be loss of visual field. This visual field loss is mainly due to the localized lesion present in the diabetic retinopathy like hemorrhages or exudates. Sometimes it is due to capillary non-perfusion area. And after the treatment with laser, there will be peripheral field loss due to PRP scars or pan-retinal photocoagulation scars. They will have difficulty seeing at night or in low light. Being particularly sensitive to glare and light, this may be due to retinal affection or maybe due to the cataract. They will have difficulty in focusing because of the weakened ciliary muscles and the weakened accommodation. Coming to the classification of diabetic retinopathy, early treatment diabetic retinopathy study have classified diabetic retinopathy mainly in non-proliferative and proliferative diabetic retinopathy, then diabetic maculopathy and advanced diabetic eye disease. The non-proliferative diabetic retinopathy is again, according to the severity, divided into mild, moderate, severe, and very severe non-proliferative retinopathy. According to ETDRS, the various features which we seen in which is seen in different stages are in mild NPDR, we will see only microaneurysm plus some retinal hemorrhage and hard exudates. In moderate NPDR, there will be mild NPDR plus cotton. All the features of the mild NPDR will be present along with cottonwood spots and or there will be IRMA, intraretinal microvascular abnormalities. Severe NPDR can be described as 4-to-1 rule. What is 4-to-1 rule? There will be features of all the features of the moderate NPDR will be there, plus one of the following criteria. What is this? The first is intraretinal hemorrhage in 4 quadrants, or there will be marked venous bleeding in 2 or more quadrants. Third is IRMA in 1 or more quadrant. Very severe NPDR will have 2 of the above criteria. Then we will say that it is severe NPDR. Proliferative diabetic retinopathy, it is also of 2 types, without high risk criteria and with high risk criteria or HRC. Without high risk criteria or early PDR comprises of new vessels or fibrous proliferation or pre-retinal hemorrhage or vitreous hemorrhage. PDR with high risk criteria is associated with NVD and NVD. NVD and NVE. NVD is neovascularization and disc or within 1 disc diameter of the disc. When it is more than 1/4 to 1/3 disc area, or it is less than 1/4 to 1/3 disc area with pre-retinal or vitreous hemorrhage. NVE is neovascularization elsewhere, more than half disc area with pre-retinal or vitreous hemorrhage. Then all these criteria will come under high risk criteria. They will require urgent treatment with pan-retinal photocoagulation. Advanced proliferative diabetic retinopathy is associated with extensive vitreous hemorrhage, precluding the grading, retinal detachment involving the macula, phthisis bulbi, or enucleation secondary to a complication of diabetic retinopathy. International Clinical Diabetic Retinopathy Severity Scale also proposed a classification which is more or less similar to ETDR's classification with slight differences. Here, mild NPDR only comprises of microaneurysms, only no other features. So, whenever the patient is presented with only microaneurysm, we will say it is mild NPDR. Moderate NPDR will come between mild and severe NPDR. And severe NPDR has 2 definitions, US definition and international classification. In a US definition, the 4-to-1 rule is applied. There will be severe intraretinal hemorrhage and microaneurysm in each of 4 quadrants, or definite venous bleeding in 2 or more quadrants, and prominent IRMA in 1 or more quadrant. International classification will have the following features. More than 20 intraretinal hemorrhage in each of 4 quadrants, or definite venous bleeding in 2 or more quadrants, and prominent IRMA in 1 or more quadrants. Proliferative diabetic retinopathy, according to this classification, has one or both of the following. There will be neovascularization or vitreous or pre-retinal hemorrhage. So now I will describe the different fundus appearance in diabetic retinopathy. So for that, we should know what is the normal finding of the fundus and what we see normally in a normal person. In normal person, the fundus will look like this. There will be optic disc with a cup, slightly faint. Usually the cup disc ratio is 0.20. This is normal vasculature, having a 2:1, 3:1 ratio. And the macula is little darker appearance. Here we can see the macula with darker appearance, and on direct ophthalmoscopic examination, we will see a shining dot due to the depression of the fovea, which is known as the foveal reflex. So this is the normal fundus picture. The earliest feature which we see in the diabetic retinopathy is microaneurysms. Microaneurysms, I have already discussed in pathogenesis. They are outpouching of the capillary wall. They are tiny red dots. Usually, first they appear in the temporal part of the fovea. This is temporal to the fovea. and they are present at the junction of the non-perfused and perfused retina, situated deep in the inner nuclear layer. They are usually on direct ophthalmoscopy. We can detect a microaneurysm only when they are more than 100 micron in size. If it is less than that, it is difficult to see. Fundus fluorescein angiography is very important part of diabetic retinopathy to detect the various lesions and to differentiate between various lesions. So microaneurysms will appear tiny hyperfluorescent dots. These are all microaneurysms in the fundus fluorescein angiography, mostly seen in the posterior pole and the macula. And in the later stages, there will be diffuse leakage from these microaneurysms. Intraretinal hemorrhage can be superficial dot and blot hemorrhage or dark blot hemorrhage. These are present in the middle layers of the retina. These are superficial hemorrhage, which are present in the nerve fiber layer. That's why they have flame-shaped appearance. Dot and blot hemorrhage have a round appearance. They are present in the middle layer of the retina. And these are dark blot hemorrhage, which are having a like blot-like appearance. They signify that whenever they are present, we should know that it is going to rapidly progress into a proliferative stage. Coming to exudates, exudates can be soft and hard exudates. Hard exudates are actually these are the yellowish waxy lesions. They are usually the deposition of the lipid and lipoprotein filled macrophages. They are also present in the deeper layers of the retina. And usually they may be isolated fine exudates, or they may be present as a ring of hard exudates, which is usually typically surrounds the microaneurysm, which is leaking. So it is leaking and surrounding that, there will be retinal edema and hard exudates. In advanced stages, there will be clumps and plaques. Whenever the leakage stops, or there is control of diabetes, or they are treated focally, the hard exudates will dissolve spontaneously, but it takes time. Over the time, it will disappear.
5 minutes.
Yeah, cottonwood spots. So these are fluffy, cottony appearance, usually present in the superficial layers. These are basically neuronal debris in the nerve fiber layer. Whenever they are present, they are actually localized infarcts, and they there is disruption in the axon and the dilatation of the one end of the axon, which leads to formation of the cystoid bodies. So with time, whenever the patient is recovering or there is good control, this will also disappear with time. Intraretinal microvascular abnormalities, or IRMA. These are fine lines running from arterioles to venules. These are AV shunts. Due to the elaboration of the vasoformative substances, this is formed intraretinally. They are often confused with the neovascularization. So on fundus examination, we can differentiate this by simply, we will see that these fine lines will never cross the major blood vessels, but neovascularization will cross the major blood vessels. And even if it is still it is difficult to differentiate between NVE and intraretinal microvascular abnormality, we can conduct one fundus fluorescein angiography, which will differentiate between the two. In IRMA, what we see, there will be no leakage of the fluorescein, but in NVE, there will be leakage and hyperfluorescence in the later stages. There are various venous changes and arteriolar changes also seen in diabetic retinopathy. Initial stages will show dilatation and tortuosity of the veins. Then we will see looping of the veins. You can see here the looping of the veins. Then there will be venous beading. You can see the bead-like appearance of the veins. Then there is sausage-shaped segmentation of the vein. All these features are seen in the severe NPDR. There are arteriolar changes. Initial stage will show that this usually signifies the ischemic stage. And initially it presents as a mild arterial dilatation, then followed by arterial narrowing, silver wiring, and finally there will be obliteration of the retinal artery. You can see here is the obliteration, retinal artery is obliterated. So it signifies that ischemia had set in, and we need treatment. Coming to the proliferative stage features like neovascularization disc is defined as any neovascularization which is present on the disc or within one disc diameter of the disc. So this is mild form. This is in this you can see severe neovascularization almost covering 3/4 of the disc. This is even more advanced stage, almost fully covering the neovascularization, disc. So this is a high risk criteria for proliferative diabetic retinopathy, and they need urgent pan-retinal photocoagulation. On fundus fluorescein angiography, what we see, these neovascularization will leak on later stages, and it will appear as an intense hyperfluorescence effect, and just like a light bulb. Neovascularization elsewhere is any neovascularization present beyond disc, and it can be mild, moderate, and severe form. In mild form, we will say small tufts of neovascularization. Here you can see there is no other neovascularization nearby. This is a fan-shaped flat NVE pre-retinally present, but there is no fibrous element. In later stage, fibrosis sets in, and there is neovascularization along with some fibrous element. So whenever we treat such patient with laser, we usually, if it is known there is no fibrous element, we should apply confluent burns on this neovascularization here surrounding, because if we apply confluent burns, there will be no leakage in future and causing the vitreous hemorrhage. But whenever it is associated with fibrosis, we should avoid treating these neovascularization. Only surrounding the neovascularization we should treat, because if we treat by confluent burns here, it will cause more scarring, and later it will lead to tractional retinal detachment. When we do a fundus fluorescein angiography for these lesions, what we see, they will be hyperfluorescent bulb-like appearance, intensely lighted bulb in the later stages due to leaking. And surrounding this neovascularization, we see these are capillary non-perfused areas. These are, you can see, and adjacent to that, this is normal perfusion. In advanced stages, there will be more hemorrhage. It will manifest as pre-retinal hemorrhage or subhyaloid hemorrhage covering the macula. Patient will experience sudden loss of vision. So whenever a patient with diabetes comes with sudden loss of vision, we should examine the patient for these features. The sudden loss might be due to the vitreous hemorrhage or the pre-retinal hemorrhage occluding the macula. Then there will be vitreous hemorrhage which may occlude the macular disc or entire retina. There will be no visualization of the retina to grade the retinopathy. In a more advanced stage, the neovascularization will be organized, scarred, and there will be fibrosis, and it will pull the retina and causing the retractional retinal detachment. Here you can see all the fibrosis causing a pull on the retina, causing traction. Neovascularization not only limited to the posterior segment, it then comes to the iris also, anterior segment, and they will, here you can see the neovascularization is present at the iris. You can see here, this is neovascularization of the iris, and finally leading to the neovascularization of the angle and neovascular glaucoma. When this stage is reached, the disease is already advanced. It is very difficult to combat the disease and to have a very good visual outcome. Only we can stop bleeding, but the visual outcome is usually not good. So it is very important to stop the disease to progress to advanced stages. We can only manage in the early stages or prevent the development of the diabetic retinopathy. Coming to diabetic maculopathy, diabetic maculopathy can present as diabetic macular edema or ischemic maculopathy. Macular edema has been defined by clinically or according to the fundus fluorescein angiography picture or according to the OCT. So the different types are, first is focal macular edema. Here we see on fundus examination, here focal edema is there. It can be seen clearly with a slit lamp examination or indirect ophthalmoscopy. So there will be raised areas of edema. Surrounding ring of hard exudates will be there. At the center, there is leaking microangiogram. So this is the area of the edema. Rest of the macula is normal. And on doing the fundus fluorescein angiography, we will see that macular perfusion is good, and there is only leaking at this area. So this is a good guidance for doing the focal laser, and we can do laser only in this area so that it will reduce the hard exudates and also reduce the macular edema. Diffuse macular edema has multiple unidentifiable source of leakage. On fundus examination, there will be honeycomb appearance involving the macula. The macula will be raised, the thickness will be increased. On fundus FFA picture, we will see typical flower petal appearance involving whole of the macula, and there is diffuse edema. On OCT or ocular coherence tomography, what we see, there are cystoid spaces in the fovea, in the intraretinal level, and the normal foveal counter is lost.
2 minutes, Doctor. You can
Yes.
summarize.
Yeah.
Yes, Doctor, please go ahead.
Yeah. So this is a OCT picture of a normal fundus and a patient with cystoid macular edema. Here you can see the OCT picture of fovea. This is normal foveal depression we see in OCT. So this is a normal fovea of a normal person without diabetic edema. In cystoid macular edema, I have described in the previous slide also, these are cystoid spaces present intraretinally. Usually it affects the middle layers of the retina, but when it is in advanced stages, it affects the nerve fiber layer and also the outer plexiform and outer nuclear layer. According to the OCT picture also, the diabetic macular edema can be classified into different categories. Here we can see sponge-like retinal swelling. There is no cystoid space, but overall thickening is increasing all the retinal layers. And the foveal depression is also little elevated. Then we see cystoid macular edema here in the OCT with raised foveal counter. There is presence of these red dots are hard exudates and macular lesions, cystoid spaces are there. Along with we are seeing a small, sorry, how it is came. Along we are, how it is.
Maybe you can use the arrow.
Yeah, yes. So why it is coming? So I should stop using it. So there is an NST or a serous retinal detachment at this place. Only on when I go there. Okay, I will not show this. Serous retinal detachment is also seen in diabetic macular edema. So coming to ischemic maculopathy, these patients, whenever the patient is having ischemic maculopathy, usually he will present with a severe visual loss. But on fundus examination, we will not see much features. Either it will appear normal or there will be little background maculopathy, as you can see here. Only the background maculopathy features are there. There is no significant changes which can indicate the presence of ischemic maculopathy. But when we do FFA, we will find that there is enlargement of the foveal avascular zone. This, you can see, this is capillary non-perfusion area. This is normal perfusion. Small areas of capillary non-perfusion and surrounding areas of capillary non-perfusion. Ischemic maculopathy is very difficult to treat. It doesn't respond to laser treatment, and anti-VEGFs also cannot be given because it will aggravate the disease. Ischemia will be aggravated. So only we have to reassure the patient. So again, I'm stressing on that before reaching this stage, the patient should control the diabetes so that it doesn't reach the advanced stages. Fundus fluorescein angiography of a normal fundus, you can see here. This is a normal fundus fluorescein angiography. The optic disc surrounding late leakage. This is normal vasculature. This is normal fluorescence, background fluorescence. No pathological lesions are seen. The macula or fovea appears little darker because in fovea there is no blood supply. So that is why it is appearing little darker. But in ischemia, you can see there is enlargement of this avascular area. This is known as fast foveal avascular zone, which has enlarged. This is normal fast and this is enlarged. And at the junction, you can see the microaneurysm between the perfused and non-perfusion area, surrounding multiple capillary non-perfusion area, non-perfusion darker area. And these are the normal perfused area. Here again, non-perfused area. Coming to clinically significant macular edema, it was defined by ETDRS research group, And this is important because whenever we see a patient with CSNE, he must be treated. If he is not treated, then definitely he is going to lose his vision, and there will be severe visual impairment. In later stages, it will cause permanent retinal damage leading to permanent visual impairment. There are certain criteria which define the CSNE. The first criteria is any retinal edema within 500 micron from the center of the fovea is termed as CSNE. The second criteria is any hard exudates within 500 micron from the center of the fovea with adjacent area of the retinal edema, which may lie outside the 500 micron limit. The third criteria is any retinal edema of 1 disc diameter, which is a part of which lies within 1 disc diameter from the center of the fovea. So all these criteria should be looked whenever we are examining the patient to identify whether the patient is having CSNE or the patient is not having the CSNE. If patient is having CSNE, we have to immediately refer him or do the laser, focal laser or grid laser according to the type of edema or localization of the edema. Diabetic macular edema is again disease severity scale, international disease severity scale has again classified it according to the findings which we see on the dilated ophthalmoscopy. So it is said to be present whenever there is no retinal thickening or hard exudates in posterior pole, and diabetic macular edema is present whenever we see any retinal thickening or hard exudates in the posterior pole. So it has also various grades. In mild edema, we see some retinal thickening or hard exudates in the posterior pole, but it is distant from the center of the macula. In moderate cases, we will see retinal thickening or hard exudates approaching the center of the macula, but it has not involved the center. In severe diabetic macular edema, we will see retinal thickening or hard exudates, which involves the center. So these we can classify the diabetic macular edema according to the severity scale also. Coming to the examination of the patient, whenever the patient is presenting in our clinic after the referral from the diabetes for the evaluation and to assess his diabetic retinopathy, we should first take detailed history about the duration of the disease, how is the glycemic control, any comorbid diseases are present like obesity, renal disease, systemic hypertension, serum lipid levels, and pregnancy. All these affect the diabetic retinopathy progression also. So we should control all these things, and we should make the patient aware of all these things. What type of medication he is taking, we should also ask about that, and ocular history regarding the previous any recent cataract surgery or any other ocular comorbidities like glaucoma, etc. present, or any other disease like uveitis is present or not, we should inquire about that. Then we will go for the examination of the patient. The first thing is we should assess the visual acuity to assess how is the patient's vision. So whether it is due to refractive error or it is due to the posterior segment affection due to diabetic retinopathy, we have to assess that. Then measure the intraocular pressure. Intraocular pressure is measured to assess the position of the glaucoma because as such diabetes is a risk factor for early development of the glaucoma. Gonioscopy or angle examination is indicated whenever we see any neovascularization of the iris or there is increase in the IOP, we should examine the angle of the anterior chamber to see neovascularization in the angle, which will decide the future treatment plan for the or we can assess there is chances of development of neovascular glaucoma. Then we have to do slit lamp biomoscopy for detailed examination of the anterior segment and posterior segment with a 90-day lens or 78-day lens. Examination of the peripheral retina and vitreous best performed by the slit lamp biomoscopy combined with the contact lens or indirect ophthalmoscopy. As here we can see indirect ophthalmoscopy, we can do the peripheral retina examination. Sometimes the neovascularization is not present in the posterior pole, it is present peripherally, so we have to detect that. So whenever we are doing a fundus examination for a patient, we should examine the whole retina. It is very important because sometimes some lesions are present very peripherally or NPE is present peripherally, which is an indication for the pan-retinal photocoagulation. So we should not avoid this. After seeing the patient and assessing the fundus, we can plan for further ophthalmic investigation depending on the stage of the diabetic retinopathy. Fundus photography can be done in normal patients, as we were discussing before starting this session, that fundus photography can be a very helpful in a primary level, because the fundus photograph can is a basic documentation for the patient, and whenever the patient comes next, we can compare whether the disease is progressed or not progressed, or it is static or it has improved. So it is very convenient, and we can very in detail we can examine the changes. So fundus photography at primary level can be done to determine the stage of the disease also. Fluorescence angiography is not routinely done. It is not a screening modality. It is indicated only certain conditions, like whenever we are seeing CSME, to guide the treatment, which areas to be lasered, we do the fundus fluorescence angiography. Then to identify the ischemic papillopathy, as I have already discussed before, to differentiate between edema and neovascularization, I already discussed. But it is not helpful when the media is hazy due to cataract or vitreous hemorrhage. Then it will be difficult to see the retina condition by fundus fluorescence angiography. OCT is now it is very handy and very important investigation. It quantifies the retinal thickening. We can exactly know how much is the retinal edema, and we can assess the edema and monitor the edema after the treatment. Vitreomacular traction specifically, it is not diagnosed with normal fundus examination. It can be diagnosed easily with the OCT. B scan is indicated whenever the media is hazy. Suppose the patient is having cataract or vitreous hemorrhage, then we cannot assess the retina. In those cases, B scan can be done only to assess the retinal condition, to see if there is a vitreous hemorrhage is there, or any traction retinal detachment is there.
Excuse me, Dr. Ushbe.
Yes.
Actually, we are running out of time. I want to give some time for Q&A also.
So I should stop here, or I should just briefly discuss?
You can briefly, if you have in like 2 to 3 minutes maximum.
Only management, okay. So we can intervene the disease in 3 stages: primary, secondary, and tertiary. Primary is only basically concerned with the tight control of all the glycemic control and comorbid factors. Secondary prevention is annual eye examination or frequent eye examination depending on the severity. Tertiary includes the definitive treatment, which includes the laser, intravitreal antiphagous injections, steroids. Then finally, in the advanced disease, vitrectomy and the other new treatment modalities are also there. Various studies have shown already that tight control can lead in delay in development of the disease, as well as slow down the progression in both type 1 and type 1 patients. The newer medical management with non-invasive PPAR alpha agonists, fenofibrate and pemafibrate, are very promising therapeutics which can prevent the development and progression of the diabetic retinopathy by regulating the glucose metabolism as well as the lipid metabolism. This is a slide showing the screening time. We have already told that type 1 and type 2 diabetes, when they are supposed to be screened, but in pregnant patients, they should be screened prior to conception or early in the first trimester. Then accordingly we can screen them. This is a table showing when to intervene and about the FFA and laser to be done in different stages. So laser treatment can be done for diabetic retinopathy and diabetic macular edema both. This is the indication when to do laser and when not to do, and when we can observe the patient. This is the technique showing the laser. We will do first inferiorly, then temporal, then we go on filling the whole of the area like this, with one spot width apart. This is the picture showing the laser scars after the treatment. You can see the pigmented scars here. There are certain disadvantages with the conventional laser, which leads to visual field loss or damage to nerve fiber layer. So this can be combated with the new advances like Pascal pattern scan laser. Here we can apply the laser marks in a pattern manner, more organized manner. They reduce the visual field loss, peripheral visual field loss, but due to the short pulse, they are difficult to do in AG media. And it is in this with pattern laser, in long term, there is more neovascularization of the eye, so it needs more research. Targeted retinal photocoagulation only after doing the FFA, we identify the capillary non-perfusion area and only laser is done in these areas. So the patient will have less field loss. This is a navigated laser and it is associated attached with a fundus camera and it is more easy to do and visualize the whole of the retina altogether. In a navigated pattern, the laser can be done. Focal laser for the diabetic macular edema. Here, the focally only this area is laser by targeting the microaneurysm and focal edema. Grid laser like this, 500 micron from the center of the fovea for the diffuse CSME or diffuse macular edema. New techniques are there for the macular edema also, which causes less scarring at the macula and less paracentral scotoma, like modified ETTRs laser and subthreshold diode laser, micropulse photocoagulation, STM. The importance is that it doesn't cause the cell death. So there will be less scotoma and it improves the diabetic macular edema. And it has been shown in various studies that it is very effective. Anti-VEGF agents can have an effect on the vasoformative substances and can be used in proliferative stage and diabetic macular edema. They have certain side effects like infection, endophthalmitis, vitreous hemorrhage, like all these things. These are the drugs which are commonly available, Avastin, Eylea, Lucentis. Steroids were used much before the invent of the anti-VEGFs. They are anti-inflammatory and down-regulate both pro-inflammatory and pro-angiogenic mediators. Different routes are available, but now they are not much used. Only in refractory diabetic macular edema, which is not responding to anti-VEGFs, we can go for this. But they cause more chances of cataract and intraocular pressure raised intraocular pressure and leading to glaucoma. Finally, vitrectomy is the last resort for the vitreous hemorrhage in diabetic retinopathy or recurrent vitreous hemorrhage or any tractional retinal detachment or rheumatologic detachment. Diabetic macular edema, if associated with vitreomacular traction or ERM or epiretinal membrane, we can peel off these membranes. So this will help in improving the diabetic macular edema. Specifically, if diabetic macular edema is not responding to any of the drugs or any of the laser, we can think of vitrectomy that improves the diabetic macular edema. Newer technique is cystotomy, which is done in refractory cystoid macular edema. Finally, in conclusion, I would like to say that the most important thing is control of glucose and lipid levels, and it is essential at every stage of the disease. Once the disease progresses to advanced stages, it is visual loss is very common and it is not recovered with any of the treatment. All of these treatments can be applied for progressive disease only, and they are targeted for vascular disorders. There is no such research or no medicine available for the neuroprotective or neurological disorders. So it is a subject of research. The neuroprotection or preventive therapy for the early stage of diabetic retinopathy needs to be developed as soon as possible with fewer side effects which are currently present. Various studies are already going on. The new medicine fenofibrate and pemafibrate, which are PPAR pharmas, are very promising and they seems to control the blood glucose as a lipid profile and delay the development and progression of the diabetic retinopathy. With this, I will conclude my presentation and thank you very much for patient listening to my presentation.
Thank you very much, Dr. Vishwan. Sorry for interrupting you. For your slide were very interesting and very attractive and covered, I think, all of the aspects related to diabetic retinopathy. And also, maybe if you can kindly go back to the risk factor that I think we need to highlight, especially as I told you at the beginning, our attendants, they come from primary health care. So that will be very extremely important for them to identify the risk factor and try to control them in order to prevent diabetic retinopathy. So apart from optimal control of diabetes and optimal control of hypertension as well, so I didn't get like pregnancy. So pregnancy, so you mean multiple pregnancy can also cause diabetic retinopathy?
Yes, it is not necessary that in all the pregnant women it will be aggravated, but it is commonly, it causes rapid progression. Yes, multiple pregnancy also will cause a rapid progression. We are seeing pregnant women in our center also. Most of them will have little rapid progression is seen in those patients. And if pre-existing disease is there, it is likely to progress very rapidly with
Yeah.
pregnancy. And
And
diabetic macular edema also develops during pregnancy, but usually it doesn't need treatment. We only need to observe very closely, and after the pregnancy only we have to assess. It usually resolves. I have seen many patients which resolve after the pregnancy. But I would like to stress on that if the patient is having a severe non-proliferative stage or proliferative stage, we should immediately go for the laser, because in pregnancy is also already a risk factors.
yeah,
So we have to do laser, and laser is not contraindicated in pregnancy, but we cannot inject the patient with anti-VEGFs in pregnant woman, because it has various side effects. So we can avoid that, but laser we can do.
excellent, excellent. So I want to remind everybody, you can put your question in the Q&A or you can raise your hand. I can see here Dr. Makari Adil raise his hand if he wants to ask. I have myself some other question, and but I want to give the chance for others. So Dr. Makari is not. So my other question to you, Dr. Abushba, for type 1 diabetes, at what age you start screening for diabetic retinopathy?
It is either 3 to 5 years, according to different studies, after the first diagnosis, and or at the achievement of the puberty. We should examine the patient, and we have many pediatric patients we are screening in our center, and most of them, they do not have any diabetic retinopathy. Only you can say 1%. We have conducted one study on pediatric diabetic retinopathy at our center also. So it was
We
very low percentage,
we have
and it
wo-
was published also in Medalist of Ophthalmology Journal.
we have one question from Dr. Saif. What are the managements for repeated VH?
Recurrent vitreous hemorrhage, usually we need vitrectomy, and
Mm,
but nowadays we can give anti-VEGFs also to reduce the bleeding. But if the patient is not responding, then we have to go for vitrectomy. But again, I would stress that if the blood sugar is not controlled, it's not going to help. The most important is all the glycemic control and the comorbid should be controlled. So recurrent vitreous hemorrhage needs vitrectomy.
excellent. And his other question, can PRP be a risk for VH?
Yes, it can be, because we are doing, suppose a patient is presenting in a proliferative stage, he is already having neovascularization and some fibrous elements. So when we are doing pan-arterial photocoagulation, we already explained the patient that there are chances of vitreous hemorrhage in future, before the future sittings. And that's why we start from inferior quadrant. So first we fill the inferior quadrant. So once vitreous hemorrhage is there, it will settle down, and it will not obscure the further the superior and other quadrants for next sittings. So vitreous hemorrhage is there. We explain the patient that there are chances of disease deterioration also. There will be chances of maculopathy also, increased macular edema also, and vitreous hemorrhage also. And there are chances of, due to scarring, there are chances that there will be retinal detachment. All this is explained to the patient.
Excellent, excellent. So my other question, Doctora, um, is there like we know that the diabetic retinopathy is a chronic process.
Yes.
Is there any like emergency presentation for diabetic retinopathy where GB should identify at spot and need maybe urgent or emergency referral?
GB, I couldn't get it.
I mean primary healthcare profession,
Yeah.
GB. So
So,
because patient come
GB,
to here,
yeah.
so is sign and symptoms that need
Yeah, signs and
emergency?
symptoms. Yeah. So whenever the patient of diabetes, they are seeing, if he's complaining of like difficulty in seeing the near objects, or if he is seeing any straight lines as rippled, or any fluctuation of vision.
No.
Fluctuation is vision, which is very important sometimes, and they will be difficult in the night vision. They will be difficulty in the uh, focusing, to change the focus from distant to near. All these are the features of diabetes, and associated Cataract and glaucoma might also add on to the symptoms, like there will be blurring of the vision. So all these should be taken into consideration. And if sudden loss of vision is there, then immediately he should be referred and examined for further investigation and evaluation.
Excellent. So, and maybe, sorry, maybe my last question, sleep apnea.
Yes.
Apnea usually does cause glaucoma. So I didn't understand how it can lead to diabetic retinopathy or like worsen diabetic retinopathy
No,
because it,
I just went through a study in that it was mentioning that if he sleep apnea and all these are treated well, anemia, hypertension, then they, in various studies, it has been seen that they delays there is improvement in the diabetic macular edema, and there is delay in the development of the diabetic macular edema. I have not gone through the details of that study and mechanism, but it has been shown in a few studies.
okay. And then briefly, Doctora, like what sort of complication that can present for primary health care for this new technology of injection and like some maybe advanced laser therapy that
Yeah.
they present to primary health care after
Yeah.
leaving the technology?
As we have already discussed that after the photocoagulation, initially the patient will may complain of mild pain or little blurring of vision, but there are chances that his vision may come down, and he will have sudden loss of vision due to sudden vitreous hemorrhage and retinal detachment after the laser also. So any such patient, if he is coming, he should be immediately referred. And complication associated with injection like anti-VEGFs, the patient will have severe pain due to increased intraocular pressure, or he will have severe pain, redness, and sudden decrease in the vision due to the endophthalmitis or infection. And sudden loss might be there due to vitreous hemorrhage and retinal detachment. All this should be considered. And sometimes due to the some wrong technique also, there is the needle might touch the posterior capsule of the lens, and the patient may develop cataract also. So all these are the complications. These are less with anti-VEGFs and and more with the uh, steroids. So all this should be taken into consideration and should be in mind and should be dealt immediately. Endophthalmitis is an emergency. Any vitreous hemorrhage or any RD or retinal hemorrhage, all are emergencies. So they should be immediately referred to the emergency.
Excellent. Thank you very much. And also, actually, I want to remind everybody about the importance of counseling patient going
Yes.
for
Yeah.
annual check.
Annual check. Yeah.
Actually, like one of my relatives who is actually highly educated, I was discussing with him how often you go to. He said, I didn't go. I said, why?
Mm.
Why you don't go? He said, because I don't have any symptoms.
Yes, yes. That I already do.
Him,
Because they don't have any mild, moderate, even in severe and severe, there will be no symptoms.
yeah,
If the blood either or glycemia is controlled, but only when the diabetic macular edema sets in, or there is a severe diabetic macular edema, and or there is a sudden vitreous hemorrhage due to proliferative stage, then only patient will have all this. We have seen many patients at presentation only, first screening, they are presenting with the proliferative stage or severe macular edema. They are not screened because they are not even some patient may be not aware, and some patient even they know, they are not taking it very seriously because the vision is not affected. That is the more main problem with this
yeah. So when I started,
barrier.
he actually said, I will tomorrow go. He never, anybody told me like this, why I need to see ophthalmologist. I am diabetic. So
Mm.
counseling patients, especially those who are declining the appointment in for in ophthalmology for annual retinal exam, actually the GB should sit with them and actually explain to them importance of going for such screening, because as you said, it is a preventable complications that can be identified early and treated before patient going for visual loss. So at the end, Doctora, thank you very much for being with us today and giving us from your time. It was very interesting and very comprehensive talk. I am sure all of the attendees have learned a lot. And actually, maybe we need you for another session.
Sure, sure. Thank you so much.
And also, I would like to thank all the attendants for being with us today, and also to follow us in our social media, and also be with us in Let's Save 11. And also this session is recorded and it will be valuable in YouTube. So thanks everybody. Thank you, Saud and Nabila, for organizing also this session. And see you next Laziv, inshallah. Thank you very much and good
Thank you,
night,
Dr.
everybody.